Thank you, Manoj, and I'm thankful to all the speakers for their excellent presentation. We'll have the house open for the questions. Let me start the ball rolling first with Sunil. Is Sunil there? Statins? Narendra. Yeah. Narendra, my question is that if you go by simple one-liner of easel, that so far as liver is concerned, statin should not be used. Will that be sufficient? Unless it is indicated for dyslipidemia or say coronary artery disease, or maybe in early stages of liver disease like NASH, in which you do not die of liver disease. By the time you have liver disease, they are more likely to be detrimental, as Dr. Bajaj said, that in later stages, it may have something like window effect in beta blockers. You will have more side effects of increasing infection or increasing toxicity with advancing liver disease. 1 minute, just hold on.
So there will be more toxicity in decompensated as compared to compensated. We lack RCTs to show benefit in patients with cirrhosis. So before cirrhosis or up to compensated cirrhosis, if LDL is high, can be used. But in child B and C, just to decrease some portal pressure or to decrease infection, I don't think.
Yeah, Dr. Solanki.
It's about vaccinations. You have a very sick patient with liver disease waiting for a transplant. How close can you bunch the vaccines to make them effective? Immunogenicity and safety.
What I meant, this is preventive hepatology, is basic. I'm assuming that you're doing this as much as you can beforehand, and you see most of them are not specific for the liver. They are basically generically what people should do. What the immunogenicity for most is going to be less, but at least they'll get some protection for this. Clearly the ones flu and pneumonia vaccine, hepatitis A, B, and of course COVID, those are critical.
Okay.
The effect might be lower, but it's still better than not having any effect at all.
How close can you bunch them? I mean, yeah.
There shouldn't be any restrictions unless they're live or, but that's more of a post-transplant thing. You shouldn't be giving live, at least in the immediate post-transplant thing.
Okay, thank you.
Yeah, Deepika.
Dr. Bajaj, I've worked in India, UK and US, and I've noticed more C. diff in our liver patients, in general in all the patients in other countries compared to India. Is it because of us eating a lot of yogurt? Because even in ICU, we do feed the patients, if they're eating, they get yogurt like at least twice a day, and we even feed them in the Ral's tube. Have you seen any studies, or have you ever done any studies? Does it make a difference? So, but why do we have less C. diff in our country compared to others?
Okay, I don't know the reason why.
But has that been studied?
It has been studied. In the cleared consortium, we found very little C. diff in low middle income countries. But again, that might have been because of the risk, people not sending the stools for C. diff rather than not having it. Because this is all dependent on how people encountering the patient think about C. diff. It becomes challenging even in the US because if people are on lactulose, it takes us on an average 2 to 3 days longer to suspect C. difficile and send their C. difficile and then wait for that to come back. So C. difficile in cirrhosis is very complicated. It has the highest case fatality rate, which we found in NAXLD as well. I'm not sure why this is not available. Assuming that it is a correct thing, that it is less available, my more feeling would be that the diversity is different because a lot more bacteria are different bacteria here. But I'm not sure that is a true observation, that it is less or more, because it has to be done with people suspecting and actually doing it.
But we are doing it in all the ICUs in India.
Not
and
necessarily.
We are actually seeing less of
Not necessarily. But I'm not talking about ICU. Most of these patients were not in the ICU.
Okay.
ICU things are, things have really crossed the... Remember, this is preventive hepatology.
Yeah.
We are kind of like, so ICU is way beyond. Yeah, I was talking about prevention of nosocomial infection.
Before they become sick.
So the whole point was unnecessary antibiotic use to prevent things such as C. difficile. So given that vein, less is more with antibiotics.
Another question I have to all our Indian hepatologists, since we've included NASH and NAFLD in the national program, why are we as an organization not being able to put pressure on the government to do something about the alcohol? It is very easily available. It sponsors such a lot of things, but I think since Professor Sareen has managed to get NAFLD-NASH into the National Prevention Program, I think we as an organization have to do something so that we can, get some ban on alcohol intake or increase the age, because we see a lot of youngsters nowadays abusing alcohol and coming with really bad alcoholic hepatitis. And they're also obese.
Yeah, I agree with you fully. Maybe government also needs revenue, so
I know, that is there. So that is why I actually did not mention that. So from cigarettes and from alcohol, they need a lot of revenue.
Deepika, I think we'll have to move on. I had posed the same question to Dr. Patrick Kamath when he had presented the ASLD 22 in Hyderabad, that why doesn't he talk to Trump at that time?
I don't want to talk to him in the future either, but anyway. So just to comment on prophylactic antibiotics, prophylactic statins. So the paper is going to come out probably in about 3 months. It's the 9-country European study, 120 patients approximate in each arm, rifaximin and simvastatin versus double placebo to prevent ACLF. So it's prospective and no benefit at all. So Narendra, the study that you showed was to look at the safety of simvastatin. So 20 was used in the study, and even with 20, there was rhabdomyolysis in patients. So not safe to be given prophylactically. And so I agree completely. Unless you have a reason for statins, no need for statins. And about the government thing, leave alone a government policy preventing alcohol. In my state, they've said their aim is to get a liquor shop within 10 kilometers of every village. Okay, that is the goal. So,
and just to reiterate that, Delhi domestic airport did not have a outlet for alcohol. But this is for Manoj to note. Now we have, even at domestic airport, it is a custom-free, so-called custom-free. So this is a new dimension to control of alcohol.
I think we have had a very successful, I would say, day one of this INAZL single theme on predictive and preventive hepatology. So I thought, let me say what INAZL is doing in this part. I was supposed to announce this tomorrow in the inaugural function, but at INAZL we have formed a task force on preventive hepatology. We had other, 10, 12 task forces, but this was lacking. So this is one we have planned, and next year I think we'll be able to show you that what INAZL would be doing in this area. The convener is sitting there, Ajit Badoria would be the convener there. So I will take this forward. The other program which we have started with from the INAZL is, again, we'll elaborate tomorrow on this, called the ROCO program. The ROCO is that INAZL has ties with the Rotary International. So this is Rotary, INAZL and Rotary program on combating childhood obesity and fatty liver program. And this has actually taken off very well, and I'll show you data that how many schools and how many children we have covered under this program, where only simple thing which is being done is only looking at anthropometry of these children in schools. And then looking at how many were found to be overweight and obese, they will go to a second step for screening for fatty liver, and similarly the parents will be counseled on that. So just a beginning I'm saying, but I thought since we are ending with day one on preventive and predictive hepatology, I think these are some of the areas which INAZL is planning. Thank you.
Just a basic question to Dr. Bajaj. By default, cirrhosis is an immunosuppressed state. So why is it there is a selective suppression of anti-inflammatory cytokines, there is an aggravation of pro-inflammatory cytokines? After all, if antigen is bringing, if it is APC is bringing some antigen to the naive T cell, which has to get differentiated into CD4 or CD8, why selective selection of pro-inflammatory cytokine?
It's not just that, it's very complicated. Initially it used to be thought, it's high inflammation. So there's a constant fighting because of the gut barrier problems. There's constant upregulation. And at some point the immune system gets exhausted. And at that point things go south. And that is much more likely in advanced cirrhosis. So it's
absolutely, it's more of exhaustion than suppression.
No, yeah, exhaustion as well, and it all depends on how quick the inflammation and infection also happens. Okay. It's not just it can be non-sterile inflammation, including alcohol-related hepatitis or any kind of acute hepatitis, on top of a bacterial or fungal infection.
Yeah, Dr. Mukul, last question.
Yeah, excellent talk with all the speakers. My question to Dr. Manoj, that prevention in hepatology, hepatitis B, the HbSAg positivity is almost up to the tune of 290 millions worldwide, and only 2% is getting treatment. So my question to you, what is your policy for those who are E negative, inactive carrier, or you can say E negative chronic infection, hepatitis B infection? So do you want to treat them all for the prevention of SCC? Or there is a very good paper in AASLD recently. There is a cohort, Egyptian cohort, where almost 2,500 patients, they were retrospectively seen, and they treat all patients of hepatitis B, and they found that those who are having low level of HBV DNA or those who are E negative, normal ALT, they are having more risk of developing SCC, and they decompensate more as compared to and they have more fibrosis also. So what should be your policy from your side in such cases?
I think there are 3 strategies, as I have said, and every country has to see which policy suits them. APASL and China are going for the treat all with DNA positive. Uzbekistan is treating all irrespective of DNA, they are just doing HbSAg, and other countries, and including WHO, are excluding patients who do not have fibrosis, significant fibrosis, who have ALT normal persistently and DNA less than 2000, in the presumption that they would have very low risk of HCC or complications. So it all depends.
So what is from your side?
I think I am a proponent of treat all strategy, because many Markov modeling strategies have shown that we have to treat everybody to at least achieve what WHO is trying to achieve by 2030. Otherwise, we are way far away from that goal. But this is my personal opinion.
Thank you so much. I think in the interest of time, we'll end this session, and thank you all the speakers and my co-chair and all the audience for being here and making this a session very interactive and educative. Thank you so much.